Dr. Charuta is a senior consultant ophthalmologist who's a cataract, refractive, and a cornea surgeon. And she is the founder of the Oculus Regeneris Eye Care and Research Center. And as you would continue to know, she's a absolutely versatile, calm, and a very confident surgeon. On to you, Dr. Charuta.
So, good evening, everyone. At the outset, I'd like to thank All India Ophthalmic Society Academic and Research Committee Chairman, Dr. Chitra Ma'am, for conducting these sessions. My video is visible and I'm audible, right?
Perfect.
So, this is a patient with relentless peripheral ulcerative keratitis, which was not responding to conjunctival resection and was on immunosuppression since quite some time. Now, his chief complaint was that he wanted to read the newspaper. So, this we just saw his outcomes a few months later. Now, I want to introduce the patient. He's a 60-year-old male. He has aggressive Moran's disease. Twice I've performed conjunctival resection and TABCL, and he's also on systemic immunosuppression for the inflammation. And in his left eye, we see that it's a really small pupil, non-dilating. And the plan that was made for him was small incision cataract surgery with iris hooks and combining it with a keratolimbal allograft. So this is the first step where I'm trying to where I'm removing the acrylate glue, and also I'm removing the epithelium, the new epithelium that has formed below the resection. Also, you can see the visible edges of the conjunctival resection, after which it has also epithelialized later. I'm not using the cautery at any point in this because the sclera is already thin and I've already used a cautery in the first two surgeries. Now, I'm just trying to clear off the epithelium, and then I'm taking a frown incision with a 15 number blade after stabilizing the globe with a very fine tooth forceps. Now, the depth of the incision is checked again with the crescent, whether it's okay all throughout, and then the tunnel is constructed, including all the side pockets. So at all points during this maneuver, the crescent blade is perpendicular to the sclera, or rather going along the curvature of the globe. So note that the blade is actually very visible through both the sclera, which is generally not an advisable thing in small incision cataract surgery. However, we are dealing with a very thin sclera and cornea here, so the normal parameters are not exactly viable. The entry with the keratomum was made around 2 millimeters from the limbus, and that would be what is desirable. Now, at this point, I want to point out that a sharp new crescent was used, and also stabilizing forceps were at every point kept away from the tunnel flap because we didn't want to injure it in any way. And again, I reiterate, no cautery was used. Also, in the next few steps, we'll see that no vectis was used because I didn't want to injure the tunnel in any way as to destabilize it. And although the tunnel was self-sealing, single suture was still used in order to secure the wound. Now, the rest of the surgery was conducted as per we would for a small pupil. So we have iris hooks which are being used, plenty of viscoelastic. Manually, the lens was mobilized into the anterior chamber and then visco expressed with very minimal manipulation. And then actually the red glow was very well visible during the case. However, it's not being captured in this system. A three-piece lens was placed, assuming that I'm not going to be able to see whether it's going in the sulcus or not because of the tremendous haziness in the peripheral cornea. So the self-sealing wound was checked again, At this point, then I went on to create the keratolimbal allograft lenticules, and then these were then fixed to the peripheral thin cornea. You can see 6 lenticules have been fixed with a combination of 10-0 monofilament nylon and suturing and fibrin glue. And the same fibrin glue and whatever possible conjunctiva was also used to close the tunnel, to cover the tunnel. So at the outcome, after a couple of months, the patient was able to actually read binocularly the newspaper, although his vision in this side didn't improve much beyond 624.
Challenging video, and must have been a great job done, is so obviously seen. What I wanted to ask was, my network is a little unstable. I would want the expert panels to support me when I get missing suddenly. I don't know what's happened. How do you, you did a scleral incision, which is wonderful, because there's no scleritis associated with PUK in this particular case. But supposing there was scleritis too, how would you have managed this case?
Ma'am, the immunosuppression would have to be stepped up a lot, much more. And ideally, the gap between acute inflammation and any surgical intervention is 3 months.
Okay.
So in this case, we've already intervened twice, and the patient was having multiple other systemic issues, diabetic and hypertensive. So we had him in a window where we wanted to do the keratolimbal allograft, and he said, whatever you do it only once. So we decided to combine both the cataract surgery and the keratolimbal allograft. But obviously, with an active scleritis, it's not going to be possible to intervene in this case at this point.
So then what is the time between the when you decide after activity, you just like uveitis, is a 3 months or 6 months? How long?
Of quiescence, yes, ma'am. Yeah.
Quiescence, and then you do it. And what is that extra immunosuppression which you give? I'm asking her questions myself. I'm sure I would want the expert panel to take some questions too. What would be the extra immunosuppression which you would add in this particular?
In this case, the patient was already on topical steroids first, which were tapered down, oral prednisolone, which was again tapered down, and simultaneously he was started on oral methotrexate. So my preferred immunosuppressive agent is methotrexate, although cyclosporin is also quite a favored one by many immunologists. So I tend to step up the dose. So if I start with 10, then move it on to 15. And then cyclosporin 50 milligrams is also another way to go. So
you have used iris hooks. They were all scleral incisions, right?
Clear corneal, no ma'am. Just at the limbus. Just at the limbus, yes.
Oh, okay. And
posterior limbus.
Posterior limbus.
Yeah.
Posterior limbus. Don't you think you could have thought of, you managed well, you could have used some endo illuminator, transconjunctival or something, or you were able to visualize?
I was able to visualize, ma'am. The red glow was quite visible after using the hooks, but somehow it wasn't captured. The place where I operated didn't have a great capturing device. Neither did I have access to an endo illuminator then.
Yeah.
Ma'am, can
I make a comment, Chitra?
All of you can comment. Yes.
Yes. Can I make a comment?
Okay. Yes.
I want to ask one question first.
Yeah, no.
So Cyrus, have to.
I want to make one comment, Cyrus.
We called you a Lord Cyrus. You are speaking next. Next.
Yeah, CHARUTA, I want to give you 200 out of 100 for this video.
Yes.
Seriously, I'm telling you, fantastic. But only thing is, why you couldn't do a phaco in this case?
Actually, because the pinpoint pupil, I couldn't assess the grade of the cataract pre-operatively. So better safe than sorry type. So I decided to I planned an SICS, then dilated the pupil intra-op. So another way to have done it would have been to create the iris ports first, iris hook ports first in the grade, but then it would still have been a hit and miss, Brunism cataract I could have missed.
Yes.
Can I comment, ma'am?
Yes, Dr. Manisha.
Yes. First of all, beautiful surgery for you daring to take on this patient is wonderful with this thinned out sclera and cornea to make the tunnel. A lot of my postgraduate students are watching, so I want to tell them to make this tunnel is extra difficult because it's already thinned out. You could have easily had a premature entry in which your iris would have troubled you throughout the surgery. The other thing is visualization is very less, and you said only 624 vision. I think in this patient, 624 vision is very good because it is still useful vision in this patient. The other thing is that would you add an anti-glaucoma agent, because you cannot monitor the intraocular pressure accurately in these patients, plus you give topical as well as oral steroids. So I think that you can add, at least for 6 weeks, a topical anti-glaucoma agent as well. The other thing, the suture. To apply a suture in such a thin scleral flap, I think your tunnel was good and you could have just left it. Sometimes you need to apply a suture, but in this, you could have just left it without that suture, especially in this patient.
Yeah.
Noted.
Yeah. These are points. Yes, points for suggestion. And
Very nice.
the thought of using anti-glaucoma medication would be more if there is a lot of inflammation in the eye. I mean, you are thinking of steroid responder.
Yes, ma'am. We get a lot of them, surprisingly.
Yeah.
So,
yeah, that's a thought. So thank you very much, Charuta. Wonderful video, and stay connected with us. I'm sure we would learn
Very
a lot
nice.
from you as we move on. Yeah, a
Thank
big
you.
clap.
Thank you for allowing me to present.
Yeah.